Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from UCB Pharma, Inc.
Hello, I'm Simona Lattanzi. I'm joined today by a friend and dear colleague, Nicola Gaspard. Hi, Nicolas.
Hi, Simona.
Today we only have 15 minutes, and this rapid fire program, we are both going to try to beat the clock and ask, can we achieve faster control of ongoing seizures?
All right, let's get straight into it, Simona. First questions. How do you define seizures? And you have 2 minutes to respond, and your time starts now.
So a seizure is a transient occurrence of signs and or symptoms due to abnormal, excessive or synchronous neuronal activity in the brain. And depending on the areas of the brain involved, so seizures can lead to motor manifestation or sensory disturbances or behavioral and emotional symptoms, and consciousness can also be impaired. A postictal state can follow a seizure and manifest as a temporary neurological deficit and or psychiatric symptoms as, for example, unresponsiveness and confusion. And most seizures self-terminate within a short time frame, which may range from seconds to minutes according to the type of seizures. And seizures emergency occur when self-regulating mechanism of spontaneous seizure termination fail, resulting in abnormally long or repetitive seizures. And the spectrum of seizures emergencies includes seizure clusters, prolonged seizures, and status epilepticus. The seizure cluster can be defined as an abnormal increase in seizure frequency compared with the individual patient's usual seizure pattern. The definition of prolonged seizures and status epilepticus depends on the semiology. So, for a prolonged bilateral tonic-clonic seizures, it is defined as prolonged when the ongoing convulsive seizure activity is lasting more than 2 minutes, but has not yet progressed to tonic-clonic status epilepticus, as per the ILE definition, is an ongoing convulsive seizure activity for more than 5 minutes. A prolonged focal seizure is an ongoing seizure activity for more than 5 minutes, but has not yet progressed to focal status epilepticus, which for the ILE definition is seizure activity for more than 10 minutes. And a prolonged generalized absence seizure is an ongoing seizure activity for more than 2 minutes, but has not yet progressed to absence status epilepticus, which is for the ILE definition more than 10 to 15 minutes.
Right, so timing is really key, right, in the definition of seizures.
Exactly. And so, Nicola, what kinds of seizures need treatment to terminate and which patients populations? And you have 1 minute for this one.
Right, so status epilepticus and seizure clusters obviously require treatment to terminate by definition. But in addition, prolonged seizures may benefit from treatment as they are themselves less likely to self terminate, especially in patients who are known to have episodes of status epilepticus. So, every patient with uncontrolled seizures, active epilepsy, and a history of status epilepticus or seizure clusters or prolonged seizures that are known to evolve to status epilepticus needs a seizure action plan, which is a pre-established strategy to prevent or respond to a seizure emergency, like status epilepticus clusters or prolonged seizures, or to tell others what to do in this situation. And these seizure action plans should cover first aid, emergency contacts, and, if appropriate, a rescue therapy to treat the ongoing seizure.
And Nicolas, what is the current best practice for managing patients with an ongoing seizures that is not self-terminating? And this time you have 90 seconds to reply.
Right. So this will depend on the setting, whether you're in the inpatient setting or the outpatient setting. However, in all scenario, every evidence indicates that um, the the parenteral administration of a fast acting benzodiazepine is the best treatment. So, the difference between the inpatient and the outpatient settings will mainly be the route of administration. If an IV line is available or can quickly be placed, and that, of course, will be restricted to the inpatient setting, or if the paramedics are called on the scene, the IV administration is, of course, the shortest time from administration to action, and it is the preferred route. In all the other situations where an IV line is not readily available, other routes of administration, such as intramuscular, intranasal, buccal, or rectal, are of course more convenient. That being said, rectal is only very rarely appropriate, and it's associated with the longest time to action and unpredictable absorption and bioavailability. So it's not probably not the best option. And of course, um, your choice of treatment will depend on which formulation or delivery device is available and how easy it is for you to administer the medication.
I'm going to interrupt you there, Nicholas, because it's now been 5 minutes since we started this talk. So a bilateral tonic clonic seizure starting at the same time would now be considered status epilepticus.
Yeah, absolutely. But let's move on a little bit. Simona, what are the challenges in these patients and settings? And I'll give you 1 minute for this one.
So thank you, Nicola. So I think that we have a lot of challenges in this setting. Maybe one of the biggest challenges is to have a drug that is quick and easy to be administered by the patients, but also by the caregiver. Of course, when we are in the outpatient setting, a drug that is easy to be administered irrespective of the types of the seizures, the semiology, and the clinical manifestation. Then we would like to have a drug with a very short time to action, so that is able to reach the active dose very rapidly, and also a drug that is able to stop the seizures but to prevent the seizure recurrence as well. And we would like to have a drug with a very wide therapeutic index, so with a very good tolerability, as side effects may sometimes limit the number of the application. A drug which is safe with no any addictive potential, for example, and also a drug with a few or no monitoring requirement.
I was looking for the magic bullet there.
And so, Nicola, what do we know about the consequences of delayed treatment of a prolonged seizure or seizure cluster? And you have 60 seconds starting now.
Right, so the problem is really twofold, right? Prolonged seizures pose two different problems. First, the longer they last, the more difficult they become to treat. And that's because of the trafficking of the receptors to neurotransmitters. With prolonged seizures, um, the GABA becomes less and less active, and GABA receptors become less available for benzodiazepines, for instance, to act. So the more you wait, the more difficult it becomes to treat a prolonged seizure. And then at the same time, longer the seizures last, the more likely they are to be associated with consequences. Loss of awareness, convulsions, progression to status epilepticus, to refractory status epilepticus, post-ictal deficit, post-ictal confusion, which sometimes can be very prolonged, injuries, respiratory complications, possibly even neuronal damage. And of course, all of this also increases the need for intervention, for emergency services, hospital admission, ICU admission, need for intubation, and this translates in higher caregiver burden and reduced quality of life. So, delaying the treatment of prolonged seizures will make them more difficult to treat and increase the risk of serious consequences.
So I think, Nicola, we can really say also in this setting that time is brain. And a really big cascade of events from single seizures throughout the seizures emergency up to status epilepticus may lead to brain damage and a lot of clinical consequences. And so it is really important to recognize when acute treatment is needed, as the earlier is the treatment and the better is likely to be the outcome.
So, speaking of time, what do we know about the time to onset of action of benzodiazepines according to the different routes of administration? Tough questions. You have 90 seconds to respond.
So I think that all available benzodiazepine treatment options are capable of terminating a seizures emergency, but each represent unique profiles. And two general issues can be considered. Point number one, The time to seizure control includes the time from box opening to administration of the active treatment and the time from active treatment administration to seizure cessation. And point number two, the pharmacokinetics of the same medication can vary based on the route of entry. So, generally speaking, benzodiazepine given by IV routes are much faster to act and associated with a shorter time to cessation of seizures once they have been injected, usually within 5 minutes or even shorter, but they require longer time to drug administration. On the other side, non IV routes usually take longer to act once they have been administered, but they have faster access. And non-IV routes usually are also less consistent in terms of absorption and bioavailability, and there is higher intra and inter-individual variability compared to IV routes. So the time to action for intramuscular administration usually is up to 5 to 7 minutes. For intranasal, usually the time is up to 7 minutes or 8 minutes, and a similar time also for buccal administration. While for rectal drug, we can need up to 50 minutes to have the action.
Yeah, so these times really sets rectal as an outlier. Uh, but it's also important to stress that even beyond this median time to action, the variability in absorption is also much higher with the rectal route, with a significant higher risk of treatment failure that you don't get as much with the other routes like intranasal, buccal, and intramuscular.
And so, Nicola, so what are the main limitation of this formulation, the formulation that currently we have? And you have 60 seconds to respond.
So there are two main limitations. As you mentioned, time to action is the first limitation. Although these treatments are fast to act, they're not fast enough. With time to seizure cessation, as you showed, that can often exceed 5 minutes. So they are slower to act than IV formulations. So not as good as the gold standard. And the key, of course, would be to find a way to deliver drugs more quickly and more easily. And the other limitation is side effects. uh, these medications are benzodiazepines, so they are associated with a risk of sedation. Although, truth be told, studies have shown that prolonged sedation is quite uncommon with these medications. Respiratory depression is also a possible concern, but it's not very frequent either. And finally, there is a concern for the potential of addiction to the on-demand benzodiazepine, although this has not really been studied so far.
So also some of the tolerability issue that you mentioned, for example, also lead to some dosing restriction with only a limited number of application allowed per week or per month. And so this can be another limit of current rescue treatment in the clinical practice. So I think that we can say that today an ideal drug still does not exist. A new option with more favorable pharmacokinetic as well as with the more favorable pharmacodynamic properties, I think would be very, very welcome.
So let's change gear a little bit, Simona. Can you tell us about the concept of rest and why it is important? And you have 60 seconds to answer.
So the rest, that is rapid and early seizure termination, is just a new management paradigm for the acute treatment of ongoing seizures. And the primary goal of rest is the rapid termination of an ongoing seizures in as short a time as possible. The rest is really important because it can prevent the progression to a worse seizure type, to a more disabling seizure type. And rest is also able to prevent the progression throughout the seizures emergency spectrum. So, to prevent the progression to a prolonged seizure or the progression to status epilepticus. A secondary goal is also the acute seizure prevention. That means the prevention of the next or further seizures in a seizure cluster. And in this case, we say about acute cluster treatment or ACT. And the benefits of rest in case of prolonged seizures and ACT in case of seizure clusters can include, for example, a reduction in the risk of injuries from seizure, the reduction in the time to return to baseline to function for the patients after seizure occurrence, the reduction of the need for emergency services, and the reduction in the risk of hospitalization, and also in the reduction in the burden on the caregiver. And another really important potential benefit is also reducing the risk of cumulative neuronal damage. And so, do you think that, Nicola, emerging rest therapy are able to address the current limitation? And you have 90 seconds this time.
So one of the first problem with these medications is that um, there's a large variability in their availability depending on where you are. And in many places, these medications are not accessible or they have to be used off label. And in particular, easy to administer formulations like nasal or buccal are not that many and they're not widely available. And of course, all of these medications are benzodiazepines with all the safety concerns that we mentioned and discussed so far. The most widely available medications, at least in Europe, are midazolam and diazepam. For midazolam, it's available as a buccal or intranasal formulation, again, in some countries, not all of them. And diazepam is available as a rectal solution. Of course, in the US, diazepam is also available as a nasal spray. In addition to these medications, there are many drugs that are currently under development, mostly benzodiazepines. We mentioned diazepam, midazolam, but prazolam is also under development as an intrapulmonary formulation. And there are non-benzodiazepine medications that are also being developed for rest. And in addition to the route of administrations that we discussed so far, there are newer ways to deliver this medication, for instance, like transdermal injection without needles, that are under investigation.
So, I think there are different treatments under preclinical or already clinical development. And so, I think they can try to overcome the unmet needs that we have, or at least some of the unmet needs that we have today.
All right, let's recap and summarize a few key points here by trying to dispel a few myths. Uh, Myth number one, Simona. Ongoing seizures don't harm the patient and they don't have to be treated. What do you think?
So I think that most seizures self-terminate within a short time frame and they do not need any treatment. But however, there are some situations when treatment is necessary just to prevent or to stop a seizure emergency.
All right. Myth number two, delayed treatment is as good as early treatment. It doesn't matter when you start treatment.
So I think that early intervention is important because the longer a seizure lasts and the less likely it is to self-terminate. And shorter seizure duration is also associated with the better immediate and also long-term clinical outcomes.
Good. Myth number three, it's better to start with a low dose than a high dose.
So it is necessary to start with the proper dose to avoid any delay in seizure termination. And the choice of the medication should be specifically tailored depending on different characteristics, the clinical scenario, the pharmacokinetic properties of the drug, and also the available routes of administration in the specific case. So, Nicola, thank you so much for this great discussion. I really enjoyed. I hope you too do the same.
Yes, thank you very much, Simona. I think that was a great, short, concise, to the point session. I learned a lot. Thank you, and thank all of you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.